Good morning and welcome to day 2 of the Independent Hospital Pricing Authority's activity-based funding conference for 2021. In case you missed it yesterday, my name is James Downey. I'm the CEO here at IPA and I'll be your MC for day 2 of the conference. Before we go on, I'd like to acknowledge the traditional custodians of the lands on which I'm sitting on today, which is the Gadigal people of the Eora Nation, and recognise their continuing connection to land, water and culture. And also I'd like to recognise all of the countries that we are, all of us meeting on around Australia today. I also pay my respects to elders today and those who walk in spirit. Well, I hope you all enjoyed yesterday's sessions as much as I did. It was great to have so many people online. We had 1,300 people log in throughout the day, so it was great to have you all here. I encourage you to use the meeting room tool so you can connect with your colleagues throughout the day and make those connections. Now, today's a really packed program and I really can't wait to get into it. Our first session is Reimagining Payment Models to Improve Costs and Care with Dr. Ezekiel Emanuel, who is currently sitting in the US at 9 p.m. at night. So thank you very much for making yourself available. And to introduce Dr. Emanuel today is IPA's Deputy Chair of the Pricing Authority, Jennifer Williams.
Good morning and welcome to day 2 of the Independent Hospital Pricing Authority's Activity-Based Funding Conference for 2021. I'm Jennifer Williams, the Deputy Chair of IPA. It gives me great pleasure to introduce the first session of the day, Reimaging Payment Modules to Improve Costs and Care, presented by Dr. Emanuel. Dr. Emanuel is the Vice Provost for Global Initiatives, the Diane V.S. Levy and Robert M. Levy University Professor, and the Co-Director of the Healthcare Transformation Institute at the University of Pennsylvania. From January 2009 to January 2011, Dr. Emanuel served as a Special Advisor on Health Policy to the Director of the Office of Management and Budget and National Economic Council. Prior to that, he was the founding Chair of the Department of Bioethics at the National Institutes of Health from 1997 to August 2011. Dr. Emanuel received his MD from Harvard Medical School and his PhD in Political Philosophy from Harvard University. Dr. Emanuel served on President Clinton's Healthcare Task Force, the National Bioethics Advisory Commission, NBAC, and on the bioethics panel of the Pan American Healthcare Organization. He's published over 300 articles and also authored or edited 15 books. His new book, entitled Which Country Has the World's Best Healthcare, was published in June 2020. I hope you enjoy his unique and informative presentation.
Thank you. It's really wonderful to be here. I wish I could be in person with you in Australia. I think it was about 5 years ago was my last trip, 4 years, something like that. And I had a marvelous time. I'm here to talk to you about rethinking payment and different models that have been tried to both improve our cost, make things more efficient, lower cost, and improve the quality of care. So I'm going to talk about 3 changes: primary care capitation, bundled payment, and a end-of-life care approach that really tries to change how we care for the patients who are have advanced illness and are going to die. Now, payment models should be designed to promote quality while decreasing costs. And typically, if they do promote quality, they can decrease costs. It's important to get the financial as well as the non-financial incentives right. Otherwise, physicians will not pay attention and change their behavior. They need alternative payments to not be disincentivized to doing the right things. So one of the reasons to change payment is not because you think doctors are only motivated by money, but it is to take away the financial incentives that make them do the wrong things. When we redesign financial incentives for physicians, we need to use behavioral economics to determine the most effective financial and non-financial incentives. You need to understand how people work, and that's part of the science of behavioral economics. Just to give you examples of what behavioral economics suggests is that you should use very large bonuses, that if you spread out bonuses in small amounts, you get what's called the peanut effect. Nothing really motivates. You should use few measures. If you use too many measures, you overwhelm people's cognitive abilities. And you want to pay extra for things you really want doctors to do. And I'll get into those details soon. So let's begin with a little behavioral economics and how we should think about these incentives for doctors. What do you think the most fundamental fact about human beings are when you think about physician incentives? Well, the key is we're really lazy. Yeah, that is meant to be partially a joke, but it is also true. We abide by the Newtonian laws of inertia, that we'll just keep doing things unless we're moved to do something other. If we don't have an external force to make us switch, we're just going to keep doing what we have been doing in the past. So that's the idea of laziness. It's really inertia. So let's think about some human laws of human behavior that behavioral economics have revealed. You might say they're obvious. I would say not all of them are obvious, but inertia, what is formally called status quo bias. We tend to favor the status quo, not changing our behaviors, doing the same habits over and over again. So we default to habits. Just think about your own practices. We keep things as they are. It requires less cognitive ability, less effort, less energy if we just do what we've been doing all the time. And almost all of us have the same behaviors. We get up in the morning, we do a series of things that are sort of pre-programmed. We also know something about information. Information by itself cannot make us change. Importantly, we need to be told 7 times something before that information sticks. Just to highlight 2 aspects of this. The first is, we often wonder, why do people smoke? Why does someone smoke? Just tell them how bad it is for them and they'll quit. Well, it tends to be that actually if you survey smokers, they know a lot more about how bad smoking is than non-smokers. It's not the information. Information alone typically does not make people change their behavior. Plus, information tends to go in one ear and out the other. Typically, we actually have to hear things many, many, many times before it actually sticks and sinks in. There's a famous anecdote in American politics from none other than Richard Nixon, president in the United States, maybe not the most disgraced. That's got to be Donald Trump, but a pretty disgraced president who had to resign because of unethical practices. But whatever you want to say about him, his unethical practices, he was an extremely astute politician. And he had this saying. He says, you say something, you say it again, you say it 5, 6, 7 times. You're sick of saying it. They're just beginning to hear it. And that is a very common piece of advice. You say the information, you say they ought to hear it. But it turns out people don't change just on the basis of information. Tell doctor something doesn't mean he or she will change. Incentives. Small victories keep us marching, but we need a goal and a direction. Just think of frequent flyer programs, right? They want you to get up to, the silver level, then the gold level, then the platinum level, and then some super stratospheric level. These are called goal gradients. You keep people doing things by setting intermediate goals and then stretch goals. We also respond to more immediate incentives rather than ones long out. We discount the future. Immediacy is a very important phenomenon when thinking about incentives. And incentives are stronger if they're distinct and explicit. If you fold in an incentive into some other pay, not as powerful. That's partially the motivation behind tips. This little cartoon says, I wrote another 500 words. Can I have another cookie? That gives you a very clear sense about the importance of incentives in people's behavior and their immediacy. Social. One of the things COVID has taught us very, very well is that we're social beings. We care about how we rank relative to others. Relative social ranking, me compared to my peers. Am I number one? Am I number two? Very important. And if you're a doctor, very important. Doctors are extremely competitive. They got to be doctors because they finished number one in their class in high school, number one in their medical school class to get into a good residency program. We are bred by Darwinian selection to be competitive and care about our social ranking. We also know something about decision-making. We can't make decisions if we have too many options to choose from. This is called choice overload. Very famous experiments. If you give people a choice of 6 things, they can choose the best. If you give them a choice of 27 things, wow, more choice, more options, should be easier. Turns out people refuse to choose then. We're also what's called loss averse, right? Before we're given something, it's got a value. Once we're given it, we want much more than that, whatever we say it was worth, to give it up. Once we possess something, departing from it is much, much harder. We think it's worth more once we actually have it. This is very important in how you structure incentives. And then willpower is an expendable resource. Making decisions takes energy. Thinking every time, I shouldn't do that, I should do this, that takes energy. And we use it up, and then we default to whatever our habit is. That goes back to the inertia point and links decision-making and inertia. If you look, for example, at judges, they make much better decisions early in the day when they're fresh than late in the day when they've already made many, many decisions. With these behavioral economic lessons in mind, things like inertia, information, relative social ranking, goal gradient, immediacy, we can think of the following practices as useful to incorporate when we want to pay differently than the fee-for-service system. More evaluative reports on physician practices to physicians, how they're doing, giving them a relative ranking to people they know. Not people like in the whole country, but other physicians who they know who are practicing in their area. Minimizing the physician willpower needed to make changes. Make things automatic and habitual. Don't ask the doctors to constantly make the new choice. Standardize the workflow so that laziness, that habit, that inertia works with you to make the right choice. Use opt-out rather than opt-in. That is, we're going to do this unless you say no. Since we're lazy, we have inertia, we're going to go along with it. You can see that, for example, maybe you know these data, but in organ transplantation, if you have people opt in to donate their organs, typically you get 10, 20, maybe 30% of people opting in. On the other hand, if it's opt out, we're taking your organs unless you object, you get 90% of people donating their organs. Same people, just how you present it, and opt out makes it much easier to go along with something. Large salient bonuses for cost and quality paid frequently based upon attainable and stretch goals, they work well with goal gradients and immediacy. And structure payment and incentives to emphasize loss aversion. So give doctors something and then say you'll take it away unless they do the behavior you think is important. Has more salience, more power. So with those principles in mind, I want to talk about primary care capitation. I've been working on primary care capitation, and I'll mention some of it for about 6 or 7 years, mainly in Hawaii, where we converted all the primary care physicians to a capitation model. In the US, I don't know exactly in Australia how these numbers compare, but about a primary care constitutes about 6, 9, certainly under 10% of total healthcare spending. But through the pen, primary care doctors impact testing, specialist referrals, drugs, the emergency room use when they send patients to the emergency room, hospitalization. It's estimated they can have impacts on 80% of expenditures, even though they themselves earn only about less than 10% of total healthcare expenditures. So they tend to be a critical pivot point if you want to control the total cost of care. Now, reforming primary care payment could address problems of access of patients to doctors in a timely way, their experience with accessing doctors, the quality of care they get, and the total cost of care, not so much for the primary care doctor, but total cost of the whole illness experience. Now, COVID has revealed the weakness of paying doctors fee-for-service every time they see a patient, right? One of the things COVID did was to take patients away from doctors, make them inhibited about going to get tests. And it's left physicians, I think, desiring some more financial stability. That's certainly true in the United States, and it may be true in Australia. Primary care capitation, paying a fixed fee for service, a fixed per member per month allotment with bonuses for quality and total cost of care, moves the physician incentive from doing more and more and doing it more quickly so they can see more patients and earn more, to providing services efficiently in their practices and ensuring that other providers are high quality and low cost. Capitation is becoming increasingly popular payment reform for physicians and payers. One of the things primary care capitation, where you're responsible for the total cost of care, aligns the doctor's main incentive, financial incentive, with being efficient and delivering high quality of care. And that's critical. We need, when we develop these kind of primary care capitation models, to recognize barriers to introducing them. One of the main barriers is physicians' suspicion that they're going to lose autonomy and lose revenue. And somehow it's a way of taking money away from them to put them on a capitated model. Payments must also assuage the fears that if physicians are paid a fixed amount month after month, no matter what they do to a patient, that they'll reduce access to services and they won't have accountability for their actions. They will become lazy. Now, as I mentioned, we did this primary care capitation model in Hawaii. We were invited in by the Hawaii Blue Cross and Blue Shield plan, which has about 60% market share in Hawaii. The American healthcare system is a little different than the Australian system, and we have private insurers that tend to pay. Blue Cross and Blue Shield in Hawaii pays when employers provide insurance. It also has Medicare, so it pays when patients are in Medicare, that is patients over 65 in the United States. It also pays for patients who are low income on Medicaid. So it has the whole range, and it controls about 60% of the fees in Hawaii. So it's the big player. We designed an innovative payment model there. We moved the primary care doctors away from fee for service to a per member per month fixed fee payment. We incorporated the behavioral economic principles I mentioned to you, and we were hoping to improve the work life for primary care doctors so that they wouldn't simply feel like they're what we call in the United States on the hamster wheel, seeing more and more patients to make revenue and living at the margin. The goal was to reduce pressure for high number of office visits to generate revenue, to allow for greater flexibilities for primary care doctors to deliver care aimed at population health and quality, not simply ratcheting up the number of visits. The old model was that these doctors got a fee-for-service payment. They got what's called a patient-centered medical home payment. This was an attempt to make them engage patients. and they got a P for Q, payment for quality. Let me just say, in the old model, there wasn't much quality delivered in return for that payment. It sort of became reflexive. Everyone was expecting the payment to be made no matter what the doctors did. The new model was we guaranteed doctors 80% of their average payment over the previous 3 years. They were guaranteed that. And then they could make 20% for engaging with the patient. That is, doing things that would make the patient experience better. Reaffirm their relationship with the patient so the patient knew who their primary care doctor. Have extended office hours, working till 8 p.m. on some nights of the week or Saturday mornings. Having more same-day visits, reserving 20% or more of their visits for same day. Introducing, this is pre-COVID, telemedicine. So we thought these were very doable changes, easy to do, and they would get the remaining 20%. So they would be kept whole with their previous 3 years of payment. Then they would have a performance measurement for quality on a small number of quality measures, 11 of them, and they would get payment for their performance on those quality measures. And then we would measure their performance on total cost of care for their panel of patients and give them incentives if they kept the total cost of care down below previous history. So what did we do before? In 2016, we had a per member per month payment, again, depending on the previous 3 years of the doctor. This is the middle column. This one, if you can see it. That per member per month varied because doctors were different. Some saw a lot of patients frequently, some saw them less frequently. So it ranged from $8 to $70 per member per month, regardless of whether they saw the patient or not. It was risk adjusted. So if they had sicker patients, they got more money for those sicker patients. Quality, initially none. After 1 year of trial with the capitation, we moved to the quality metrics. And they had incentives for engaging, as I mentioned, 20% incentives that would change for the simple changes like same-day visits or extended office hours. And then we had a quality program with 12 to 13 measures. You'll see we started out with 13, but went down to 12. Now, as I mentioned, we need to think of these primary care capitation models based upon behavioral economic principles, things like goal gradients. Here's your quality gradient, try to get to it. Inertia, recognizing that if we change things to make it easy, we habituate, we standardize, docs are more likely to do it. We also gave them information on their relative social ranking. How were they doing in terms of quality, total cost of care compared to their peers? And we made sure there was not information overload. When we think about primary care capitation as a result of our experience, we have identified 7 design elements we think is critical for successful capitation models. First, maintain or increase primary care payments. Baseline capitated payments to primary care doctors should be derived from the risk-adjusted average fee-for-service for the previous 3 years. They should not lose income. You can't say we're introducing this and we're going to take money away. They just won't buy into it. Similarly, we think they actually should increase their payment. You should invest in primary care. Slightly higher capitation amounts, recognizing the need to invest for them in redesigning how they're delivering care and their workflows. They need to redesign, for example, to get care coordinators to focus on patients who have chronic illness and are very likely to have serious exacerbations, whether congestive heart failure, COPD, diabetes, and give those patients more attention. You want to invest in their paying attention to the quality metrics and being informed about them. You want them to invest in mental health care. Over the longer term, higher payments to these doctors after the initial investment for them to transform their delivery should be linked exclusively to improving the quality of care or total cost of care, not to changing the per member per month payment. Doctors need to think this capitation model is not what we call a flash in the pan or a passing fad. If you're asking them to re-engineer their office workflow from fee-for-service, seeing lots of patients, to capitation, where they're seeing the patients who need to be seen for a long period of time, for the others who are the worried well that are dealing mostly in telemedicine, that requires a significant investment. That investment will only be seen to be worthwhile by the doctors if they get an increase in payment and believe the capitation is the new normal, not a temporary measure. 5-year contracts provide that assurance. You should pay the primary care doctors for evaluation and management services the capitated payment. You should add on to the capitated payment partial fee for service, paying fee for service for the services you want them to do, because those services are proven to be beneficial for patients, and they might not get done if you leave them for the capitation. These include things like having immunizations, adult immunizations. You want doctors to do that, whether for flu or for pneumococcal pneumonia or for shingles, pay them for the immunizations. Referral management. You want them to manage the various different doctors for patients with chronic diseases, whether cardiologists or endocrinologists. You should pay them extra to manage those referrals. You want to pay doctors for seeing patients within 7 days of an emergency room visit or a hospitalization, because we know that, will prevent rehospitalizations. You want to have doctors try structured medicine holidays so that we don't cause the problem of polypharmacy, but doctors actually do that. Again, fee for service. And we want to pay doctors to do procedures that they might otherwise refer out at higher cost facilities like hospitals, things like joint aspiration. We want the incentives to engage patients. As I mentioned, we want the patient experience to improve, and one way to do that is to give doctors incentives to enroll patients, influence who's on their panel, give them visibility to the patients they have, who they're being paid for, and let them know month to month and quarter to quarter who's leaving their practice, who's joining their practice, so that they can actually be aware of who they're responsible for, and incentivize them to actively affirm their primary care relationship with the patient. We should also incentivize primary care doctors to make seeing the physician more convenient and easier. As I said, establish and retain telemedicine. We've seen telemedicine go way up because of COVID and then drop down very rapidly when the offices reopen. We don't want that. You want telemedicine to stay up. This is a way of encouraging it. Extend office hours until 8 p.m. on weekdays so patients can go to them sometimes. Many more same-day appointments and weekend hours. Here's the data on within a few months when we had these engagement incentives. 20% of the payment was an engagement incentive. How many doctors just within just a handful of months did these things? Almost 60% reaffirmed their relationship so the patient knew who their primary care doctor was and to call them first. 50% increased non-face-to-face communications, whether telephone or video. 50% increased the capacity of office staff to address gaps like ordering mammograms or colonoscopies or making sure patients were taking their medications. Spent more time during office visits with chronically ill patients. A third of them made more availability for same-day appointments to see patients who were sick that day rather than send them to an emergency room, which was expensive. And 30% pre-COVID actually introduced video medicine appointments. 6, provide cost and quality incentives. Provide a 20% bonus for total cost of care and keeping it down, and quality improvement. Bonuses only on a few salient quality measures. As I mentioned, we had 12. Bonuses need to be salient and timely. They need to be large to engage physician attention and paid at least quarterly, not annually, so that doctors know what that they're being bonused and incentivized for doing what they should be doing. And they should be paid in a separate check so physicians see how much they've made from the bonuses for quality and total cost of care. They shouldn't be folded into the regular check that goes into the doctor. Otherwise, it's lost and has no incentive role. When we did that, we had these quality measures were developed by the payers and the doctors. Advanced care planning, filling out a living will, you can see substantial increases. Assessing patients for their body mass index and beginning to discuss with them how to control their obesity. Enhanced breast cancer screening. We saw cervical screening go down, actually. Childhood immunizations, largely unchanged. Colorectal screening, unchanged. But diabetes care, controlling blood pressure, controlling sending patients for eye exams, very important increases. So you can see we had actual serious improvements in quality after only a few months. Finally, don't make money everything, right? It's not all about financial incentives. There's also pride in work. PCPs want respect for their expertise, autonomy in the practices they see fit, and flexibility over their time. Capitation can eliminate many aspects of the monitoring of them and their feeling of being watched. We also combine that PCP capitation with physician feedback, giving physician regular and salient feedback on how they're performing in terms of patient enrollment, total measures of quality, and total cost of care. They lack this information. Do you know how you stack up in terms of ordering MRIs for back pain compared to your doctors? Or what percentage of your patients are up to date on their cancer screening? Or how well your patients with diabetes are doing in terms of control of hemoglobin A1C compared to your peers? We provide that physician feedback. We make these physician report cards available electronically to them and by mail. And they're designed with behavioral economics in mind. That thumbs up for a good job, very, very positive responses by doctors. We give them their performance. On the right side, you see the improvement goal at 61%, and then the stretch goal, and they can see exactly where they're at. You can see if you want to shift them to have their doctor send patients to preferred facilities, whether for imaging or laboratories, what they've done. So we create these reports for them. We also do that in terms of the financial incentives. We report how much they've earned. Again, positive thumbs up. When we want them to refer to high quality doctors who are very efficient, we give them a list so that they don't have to figure who they are out. We show them how their referrals have gone to those doctors. We also, on the bottom, where they've earned a bonus, we remind them of how much they didn't earn but could have earned to emphasize loss aversion. These are really important. This is a list of referrals for cardiologists. Rather than give them everyone, we want ones who are high quality, patient have high satisfaction, and are not excessively driven to test ordering. And so you give them a list and you rank the doctors with stars about ones that they've used before, that they have relationships. This gives a lot of salience without lots of excessive information so that we don't trigger choice overload. We star the ones they use and indicate how high quality they are on the right. So that's primary care capitation with substantial incentives. Next, I want to talk about bundled payments. What's bundled payments? Well, the traditional fee for service is we split up fees. We pay doctors for pre-admission services. Then we pay the hospital for services. We pay doctors for seeing the patients in the hospital. We then pay per post-hospitalization, whether rehabilitation or skilled nursing facilities. And if a patient comes back, we pay again. Bundle payment is saying we're not paying each individual part. We don't buy a car by a carburetor, then the transmission, then the tires, and then we put it together. We buy the car. It's all put together. Similarly, we should buy medicine. It's all put together. And so bundle payment is paying one fee for, say, hip replacement or cardiac catheterization or a CABG surgery that covers everything: the pre-hospital workup, the hospitalization, the surgical procedure, the anesthesiologist, the surgeon, and 90 days after the hospitalization for any complications. In the United States, the federal government has instituted what's called the Comprehensive Care for Joint Replacement model. It's a mandatory model. They go into regions, and every hospital in the region, every orthopedic surgeon in the region has to participate. Initially, it was 67 regions and 800 hospitals. The Trump administration rolled it back to 400 hospitals and 34 different regions. The episode of care begins with the hospital admission and ends 90 days after discharge. So if a patient gets a complication like a wound infection or some other complication from the, say, artificial joint not working, you're responsible. That incentivizes high quality. It covers the hospital, the physician, rehabilitation services afterwards. And the hospital is also responsible for all the services afterwards. You need a home visit? That too. You can see it led to reductions in inpatient rehabilitation. So one of the things that immediately happens is instead of sending patients to rehabilitation hospitals, send them home and send the physical therapist to the house. It turns out to be cheaper. Save on not sending them to nursing facilities. You spend more on home health, but fewer dollars on readmission because you're focused on quality. You're focused on maybe treating them at home instead of in the hospital. And doctor fees go down. There's savings. Unplanned readmissions go down. Complication rates go down. And so in general, things have been good. This mortality rate increase is not significant. Bundle payments can be potentially implemented in a few areas, and the main areas that we have found them successful in experiments in the United States are procedures. They work much less well for medical activities like congestive heart failure exacerbations. They've worked for cardiac surgery, cabbages, cataract surgery, cardiac procedures like catheterization or valve replacements, radiation oncology, back surgery, renal dialysis, and we're proposing that they might be used for reimagining end-of-life care. So I want to talk about, in the final minutes, a proposal that we're launching with a major insurer in the United States to create a different model for patients with advanced illness who algorithms predict are going to have a high likelihood of dying in the next year. I don't know about Australia, because while I studied end-of-life care and compared it in multiple countries, Australia couldn't produce the data in a timely fashion. But spending in the last 6 to 12 months of life in the United States is responsible for about 25% of all spending for patients 65 years and older. Why? Because those patients tend to die at a high rate. About 5% of them die every year, and they consume a lot of money. End-of-life care is very expensive. In the United States, end-of-life care in the last 12 months of life consumes about 10% of all healthcare spending. We're proposing that early home-based palliative care, not end-of-life care, begins 12 months before, can improve quality of life of patients, lower end-of-life spending by preempting hospitalization, emergency room visits, and improve the experience for patients and their caregivers. We call this Comprehensive Care at Home program. It's a home-based primary care program for seriously ill individuals who are likely to die. This comprehensive care program is the first program to integrate multi-evidence-based components of end-of-life care. Each component has been looked at and studied and makes a big difference, but never integrated fully into one comprehensive model. So the first thing is to have multidisciplinary teams care for patients, a physician, a nurse, social workers, psychologists, dietitians, pharmacists. Tier the interventions linked to the patient's health status. Early on, 12 months before you anticipate the patient might die, probably don't need that many interventions. As they get closer to death, many more interventions. Proactively identify patients at high risk of death. Don't rely on doctors identifying them, because we know doctors are reluctant and often do not accurately predict which patients are going to die. You have to proactively identify them and create an opt-out program. Enroll all the patients you've identified. Don't ask doctors to enroll them or to talk to them, because data shows they won't. None of us like to have that conversation. So we just say to the patient, we're going to provide you comprehensive care at home. You can refuse, or your doctor can refuse, but that's the default we're going to use. Again, using behavioral economic techniques. Give them 24/7 support, a line they can call, a nurse they can contact with who has their case, and move them into hospice early if things are getting worse. It emphasizes enhanced social supports, including nutrition, mental health services, because these patients can be depressed and anxious, and caregiver support because their caregivers, their loved ones, can also have health problems. Close coordination with their primary care health team and hospice. Early initiation of home-based care to enable the patient and family close rapport with the home care team so that they won't, acutely go to the hospital. As we say in the United States, I don't know what the number is in Australia, but 911, that's the emergency services. They don't call that. All of these interventions are validated on randomized controlled trials. Again, each piece has been tested, but never comprehensively together. And again, emphasize, we want to use the opt-out. Patients automatically enrolled to overcome physician hesitancy of talking about end-of-life care with patients and acknowledging patients' critical situation. We want to overcome the inertia. Similarly, it's easier to continue established care at the home when it's begun well before death rather than calling the ambulance. So this is the team. It's led by a nurse practitioner. It has all these others, palliative care doctors who can review and be called in if palliation is needed and for complex cases. The primary care doctor, the oncologist, the cardiologist is there. Chaplains for people who are religious, nutrition consults for people who might have nutrition and dietary problems, social workers. Now, a study of usual care versus in-home palliative care delivered by an interdisciplinary team, but not with all the other items we had, showed a 12% increase in patient satisfaction, a 20% increase in deaths at home rather than in the hospital, a 13% decrease in emergency department visits, a 23% decrease in hospitalization, and a 55% decrease in the cost of care per day. That's really important. Tiered milestone-based palliative care that I mentioned, screen the patients with an algorithm to identify high-risk patients. Algorithms are not great at identifying patients near the end of life. So you have a secondary screen with a clinician looking over the patient to see if what the algorithm, based upon machine learning, has identified really corresponds to good clinical judgment. Then you have a nurse practitioner assess the patient in their home. They use a pulse, that's basically a DNR order, to discuss with the patient. They also talk about advanced care planning with the patient. They then stratify the patient. Is the patient so sick that they really need hospice right away? Is the patient actually not that sick that they shouldn't be in this program? And then for the remaining patients, they have tiered home care. Early on, maybe monthly visits, accelerated up to daily when the patient become much sicker. They check in with telehealth and again, accelerate that if it's appropriate. When might they reevaluate patients? When they get hospitalized, if they go there or they visit the emergency department. If there's a decline in their quality of life or increase in their symptoms, they get added pain, fatigue increases, dyspnea increases, or if the caregiver thinks that they need more services. Patients who are enrolled to receive tiered care will be graduate from the program if they don't have inpatient visits for 6 months. Their symptoms improve after enrollment. The nurse practitioner assesses them and doesn't think they're appropriate for the program, or the patient wants to opt out. We also want seamless transition to hospice. This is a palliative comprehensive care model to provide primary care as well as other services. It's not hospice. We then integrate to hospice if that's appropriate. The nurse practitioner who's been seeing the patient continues upon that hospice transition, and we can provide other medical supports to the patient, transfusions at home, other supportive care as appropriate. Other elements, immediate flag to the team upon an emergency room visit or a hospital visit so that the team knows when the patient has visited. Sometimes that communication loop doesn't get closed. As needed telemedicine visits between the primary care doctor, the patient, and the multidisciplinary team caring for the patient to ensure seamless communication. Integrated behavioral health to mitigate patient and family anxiety or depression. Backup security in uncertain geographic areas that where it might be dangerous to visit patients, and weekly communication with all take with all patients. So I want to just end and open it up to some of your questions. Behavioral economic principles such as goal gradients, salience, loss aversion should inform payment model structures, relative social ranking to help give feedback to doctors. While primary care capitation and bundle payments have the potential to reduce costs while improving quality and patient experience through restructuring of financial and non-financial incentives, we think they're a good way to change how we incentivize doctors to provide high quality care and keep total cost of care under control. End-of-life care also can benefit from alternative design and incorporation of behavioral economic principles and more comprehensive care that begins early and that opts patients in rather than opts them out. So thank you for your attention. And I think we have some time for questions, if I'm not mistaken.
Excellent. Thank you very much. A fantastic presentation. And we have got a raft of questions. Now, I'm not going to try and get you to answer questions that are about the Australian context. I think that'll be a little bit unfair. There's a lot of questions around how do you measure the quality. So I think you mentioned 11 quality measures. I think people would be very interested to understand, because I think for us, that's going to be the sort of the crux of it all, isn't it? That how do you make sure you're not foregoing care or having worse outcomes in a capitation model?
So it's really, that's absolutely really important. So think about items that you might care about. One of the things that we did in Hawaii when we designed the quality metrics, the insurance company had things they were worried about. For example, there's a big problem of obesity and diabetes because of the South Pacific population in Hawaii, and they were concerned about diabetes and incorporating that. So we looked at proven diabetes quality measures, blood pressure control. Is it under 140? Now it should be under 120. Hemoglobin A1C, under 9 and preferably under 7. And again, using goal gradients with them. Are lipids measured? And if the lipids are high, are they on statins or other medications to control the lipid levels? Have they seen eye doctor for diabetic retinopathy in the year? Have they seen a podiatrist for potential podiatry problems that could easily lead to gangrene and hospitalizations? Those are the package of 5 diabetic measures. They're all quality measures. They can easily be gotten from laboratory data or reported on clinical data. Similarly, for patients with hypertension, we know controlling hypertension is probably the most important thing that all of Western medicine has done in the last 60 years to reduce mortality, right? Even more important than smoking cessation in the United States context was reducing blood pressure to decrease stroke and heart rate. That's an easy quality measure to get out of an electronic health record and to measure. We can also look at other quality measures with different kinds of patients. Another measure we look at for diabetic patients is the number of emergency department visits for either hyperglycemia or hypoglycemia. You can look at admissions for congestive heart failure or exacerbations. Again, there are a whole variety of measures. One of the things we're doing with oncologists in cancer care is to also look at patient-reported outcomes. Their depression, are you actually measuring it and addressing it? Similarly, you can look at typical cancer screening tests. Women get their mammograms as they're supposed to, colonoscopies, cervical cancer screenings as they're supposed to. So I think we have lots of quality measures we can get out of either electronic health records or claims. And one of the things we did in Hawaii was to consult with the doctors. How would they like to be measured? What are the things they want to be measured on? And so we used a large number, about 60 quality measures that we started with, and working with the doctors and the payer, we honed those down into ones that were salient.
Excellent, thank you. And you had me at Hawaii. Sounds like a good place to do a trial.
You think it's good. Let me just say, when you're flying to Hawaii from the East Coast of the United States, it's 13 hours. It's like flying to Abu Dhabi. You don't go for the weekend.
Oh, we do in Australia. We love to travel. A question from one of our board members. I think in the US, your organisation of primary care providers is quite different to ours. Have you done any work on, is there a minimum size that you need to make this work? Does it work with you? We have a lot of sole practitioners here in Australia.
So that it turns out that in Hawaii, there are lots of what we call in the United States onesies and twosies. Yes, solo practitioners, small groups. And one of the things we do think it helps to have a larger organization. So one of the things we did was to make physician organizations where we brought the onesies and twosies together to share best practices, to discuss how they're seeing patients, how they're capturing or what they're doing with the information that they're getting back and the relative social ranking. It's hard, I think, for individual doctors to have the time to really transform their care, to have the staff, and bringing them together can help with, for example, same-day appointments. Well, if I can't see you, maybe my colleague can. Opening up at night. This is something, by the way, that is done in the Netherlands. They have large groups of primary care doctors, each one working independently, but they come together to provide night coverage, weekend coverage for other doctors. So they have access to their medical record, they see the patients, and they just don't go to an emergency room. So I do think that does require additional work of trying to create these physician organizations where that can help the doctors come together, share resources, share best practices, share their experiences, and maybe even share practices like call, same-day appointments, etc.
Great, thank you. And then a question around the end-of-life care work. How do you identify patients who are going to be eligible? Is it prospective or is it retrospective?
So we've been working on, there are various algorithms that have been used in the United States. And let's just say they're good, but not great. So they can identify 50 or 60% of patients. Some of them, they will not actually be end of life. They might have had a very bad hospitalization in the year before, but they won't. If you look at the medical record, you say, oh, this is not a terminally ill patient. This is just a patient who needed a lot of resources last year. So we basically run some machine learning algorithms on claims data. And then, as I mentioned, we have a clinician check to focus in and try to identify those who are really by clinical criteria, not just what the claims say, are sufficiently ill. And then we have a third level of checking, which is the nurse practitioner goes out and sees the patient, and she or he makes a determination about, well, this patient really isn't that sick. We got the machine learning got it wrong. And by those three hurdles, you can actually identify those patients pretty well. It's not a perfect system. And interestingly, just using claims is far from perfect. Now, you can soup it up if you focus in heavily on, say, oncology, where, patients who have poor performance status or metastatic solid tumors, you have much better indications. But you want to use this model for not just oncology, for also, end-stage congestive heart failure or end-stage COPD or other conditions.
And then I guess one last question, it's really from me, around the capitation. What was the trigger? We talk a lot about technical and the risk adjustment and the payment model and organisation of doctors, but the politics is always critical in this. What sort of got this going, and how was it sold? What was the What was the what were the main resistance in the system to it? What was the inertia?
So there are several things. It's a great question because you would think it should happen. So in Hawaii, it turned out that the head of the insurance company was going to retire in a few years, and he wanted to leave a lasting legacy. And he saw the future that fee-for-service was not the way to improve quality and get a hold of total cost of care. Affordability in the United States is getting to be a big issue, and he thought he needed to shift to capitation to get long-term, more affordable care. That's the motivation and the politics within the payer. In the community, doctors in America are very suspicious of capitation because we tried it in the 1990s and it failed. We didn't have information systems. We didn't have good guidelines. We didn't really understand behavioral economics and how to integrate it. We didn't give physicians feedback about how they were doing. And so they view it very suspiciously, those who remember, and they're also worried that it's just a trick to take money away from them. So one of the things we had to do is to show doctors when we have a model, that electronic model, how much they're going to be paid in the capitation and compare that to their fee for service. Now, today, the politics are a little different. Primary care doctors are sort of becoming exhausted with the fee for service rat race. Importantly, also, COVID made clear to them that their situation can be very precarious based upon factors they can't control. Providing more financial stability is something that a lot of them like. In addition, when we show them what they'll earn under the capitation model with bonuses and given their quality and what they get for fee for service, for many of them, it looks quite attractive. And we indicate to them that if they improve their quality, or they control the cost, and we talk about, a few of the things that they can do, that they can really begin to make 10, 20, 30% more, that gets their attention because primary care doctors aren't making that much money. And, if you pay them $20,000 more, they can earn $20,000 more by doing good quality. They really begin to like the system. But it is a learning process, and it's not something that happens overnight. Changing doctors' mental frame from fee for service to I do have to do it differently when I'm being paid capitation is hard work because we're lazy and we have one frame. We're used to it. Our whole career has been developed on that frame, and we've sort of optimized for it.
Well, thank you very much, and thanks so much. It must be 10 p.m. there. Thanks so much for the late night call. I think we've just looking at the questions, there's a lot of engagement, and I certainly learned a lot. And we look forward to catching up with you in person at some stage in the future. I'll say it in public, we do have a deal that as soon as borders are open, you're very welcome to come out and spend some time with us. And we hope everything in the US is getting better, certainly a lot better since the first time we spoke in January anyway. So thanks very much for the time, and thanks on behalf of everybody at the conference.
My pleasure, and great questions. And, we're always here to help implement these things. This is something, as I said, we've been working on for a long time. And I feel a little bit like I'd like to spread the word and have other people try this if they think it can improve the quality and cost of their system. Thank you. And I really do look forward to coming to Australia and meeting as many of you as I can.
Awesome. Thank you very much.
Take care.
Okay. And now it's time for everyone to jump back to the timeline. And then our next session is a very unique opportunity to have a question and answer session with Professor Stephen Duckett, who is the Health Program Director at the Grattan Institute. And many of you will know him as an expert in ABF and the Australian health system. So look forward to seeing you back here very, very shortly. Thanks.